what do you do with the teenager? Somebody who's between 12 and 18. Do we manage them according to criteria for children or criteria for adult? And this is where I say that this is where teenagers behave just like adults, and it's probably the only situation where teenagers behave just like adults. And that is, I think they really should be managed according to adult guidelines. So have you all heard about Z-scores? All right. Well, listen, I didn't do too well in statistics in college, so take what I say with a grain of salt. So this has to do with measuring what's called a normal distribution. That is, you take 100 people off the street. If it's an American male, the average height's going to be about 5'10". And then there's some who are way out over 6 feet tall, and then there's some who are down there by around 5 feet. And if you plotted the number of people who are at 5'10", and then the number who are at 6'5" and 5 feet, that curve, if you will, is going to look like what they call a bell curve, with a lot of people in the middle, but not so many out here on the side. And there are points at which you can say that I'm struggling with the right word here, and trying to avoid the term standard deviation, which is the one that I want to use. What you can say is that at about 95% of the people will fit in a range around that middle that is defined by one Z-score. Actually, I got it a little wrong. About 2/3 of the people will fit within one Z-score of the middle, or the mean, okay? And 95% of them will fit within 2 Z-scores. And so a Z-score is how many standard deviations from the mean are you sitting at a particular time. So a Z-score just tells you how far from the average you are. And if you're 1 Z-score from the average, it means that you may, you're still within a normal range, but you're up at about the 67th percentile or something like that. But if you're 2 Z-scores, you're up at the 95th percentile. It could still be 100 normal people, though. That's the thing that I have trouble with Z-scores. It's just telling you how distant you are from the average. But I don't like using Z-scores as the threshold for doing the surgery, because we don't really want to know how far from average you are. We want to know what's the risk of being where you are. And for certain features, the Z-score doesn't matter. For height, for instance, if your Z-score in terms of your height is 2, you're at the 95th percentile. Well, there's no danger at being at that height. And if your Z-score for the size of your aorta is 2, your risk is probably going to be higher, but we don't actually know what that risk is. It's not based on Z-score. It's based on other things that we haven't figured out yet. I feel like I've just confused people in this room more than anything. But just use it as this. It's a measure of how far away you are from the average. And 1 Z-score means that you've gone from the 50th percentile to the 66th percentile. And 2 Z-scores means that you're out there at about the 95th percentile. And so when you start hearing Z-scores of 4 and 5, it means that you're really way out there on the extreme, but it's not telling you when to operate. That's the point I want to make. Don't be lured into thinking that a Z-score tells you when to operate.
Well, it was presented to us that he's a 2.9 on the Z-score, and you would do preventive operation. So what do they communicate there in plain?
I'm disagreeing with that. I'm saying you don't operate on the Z-score. That only tells me how far you are from the average. It doesn't tell me what your risk is of rupturing your aorta.
So what's my measure to say we operate or not?
I think it's the absolute size of the aorta, not how far you are from the average for your size.
So that's your 3 centimeters.
That's the 3 and the 4. Those are sonometers. Those are absolute measurements. Now, I would say that might actually be cruder insofar as it doesn't take into consideration big kids, small kids, big adults, small adults, but at least it's based on something real. You know, surgeons still can't figure out whether we should be indexing the size of the aorta to the patient's size in terms of when should we operate. We haven't settled that question yet. It seems obvious that you should, but there are good arguments against it. They say it doesn't matter whether the aorta is sitting inside a big person or a small person. It's a balloon, and you can imagine you're blowing up a balloon in a car, and whether that thing ruptures doesn't matter how big the car is. It's the size of the balloon and the pressure in it. So,
with the 3 centimeter size, is that relatively new decision? Or?
No, I think actually, and you know, Dr. Dietz sees more people with Loeys-Dietz syndrome than anybody in the world, and his feeling is that that's where the threshold should be until we get more experience. But it's not recent. No, I would say that's been in place for about 3 years. Sorry?
We're under the understanding that children is
no.
Our daughter's at 3.6.
How old?
10.
Yeah. I think you need to have a conversation with them.
How big is a large adult's?
I'm sorry?
On average, how big is a large adult's size of visit? It's like a large grown-up.
I'm sorry, I still had trouble hearing.
A large grown-up, what's the average size usually of the aorta? A healthy person.
All right, so what is the size of the aorta in a normal adult? And it's about 3 centimeters. It's 2.5 to 3 centimeters. Yes.
As far as Loeys-Dietz children are concerned, what's the youngest age that you replacement?
A replacement as opposed to, I would say it's about 2 years.
2 years old?
Yeah. It's
That's replacement they end up going with metallic.
We've done both metallic and the homographs. The pig valves are not available in those small sizes, or even the cow valves, but the human valves are, and even the mechanical valves are available in some smaller sizes. You're touching on another question, another good question, that the children who need the surgery early in life, they tend to have an aortic valve that's already big for them, and that if you put in, or if you keep the valve that size, which happens when you replace the root. I didn't say this explicitly, but once you do a root replacement, you put a plastic tube around that valve, it's not going to grow. It's stuck that way for the rest of the child's life. So we often like to wait, if we can, until the aortic valve diameter is 20 millimeters, 19 to 20 millimeters, because at that size, we know that even if it doesn't get bigger, it's big enough for an adult. Unfortunately, most children who need this surgery have bigger valves than other children, and they can get an operation that theoretically could last them to adulthood. So the question is, an operation done about 5 years ago, when she was 10 years old, how long will that last? Theoretically, it can last a lifetime. Seriously, we don't know for sure, because this operation's only been around for 15 years. But as long as those flaps, the leaflets, continue to work well, it should last a lifetime. Now, there are some concerns that having these flaps open and close inside a rigid plastic tube may put unusual stresses on the flaps, and maybe they will start to weaken over time. My feeling is that even if this operation only lasts 10 or 15 years, that's getting young people through adolescence and early adulthood without mechanical valves and without valves that are going to fail in less time. So it's still better. It's still better.
One question is, what are some signs of wear and tear of the valves, and does that prevent the echocardiogram?
Yes, the wear and tear of the valves is seen beautifully on the echocardiogram. You do not need catheterizations. And actually, you can just by listening with a stethoscope, I can tell you that if there are no unusual murmurs with the valve, then it's probably fine. Yes?
In your presentation, you
from my family, that's how our Loeys-Dietz syndrome journey started. My husband, it's been nearly 4 years, had type A dissection of the thoracic aorta, and has had other surgeries since, other complications, other aneurysms, has some that we're watching now. But here, almost 4 years later, it seems fairly stable. Do you have data at this point on sort of prognosis following acute emergent dissections and you know what comes down the road thereafter?
Sure. So the question, if you didn't hear it, was if you've already had a dissection involving your aorta, and you may or may not have had surgery to replace the first part of it, of the aorta, but the rest of the aorta still has a dissection in it, are there data to tell us what to expect in the future? Can you make a prognosis? The answer is no, not for Loeys-Dietz syndrome. We do have it for people who don't have Loeys-Dietz syndrome and some Marfan syndrome patients, but not enough to say anything long-term about Loeys-Dietz. If Loeys-Dietz syndrome patients turn out to be a lot like other people who've had dissections, then we can say that about 1/3 of them will end up needing more of their aorta replaced eventually. My suspicion is it's going to be a little higher than that for Loeys-Dietz.